Welcome to Rare on Air, the monthly podcast from EURORDIS Rare Diseases Europe. I am your host, Julien Poulain, and once a month, we will be exploring the challenges, experiences, and successes of people who live with a rare condition. In today's episode of Rare on Air, I speak with Dr. Miriam Wilms. Miriam is the mother of a young boy born with an anorectal malformation, and she's an advocate at SoMA, a German non-profit organisation supporting families impacted by rare colorectal conditions. As a visceral surgeon and proctologist, Miriam brings a unique perspective, blending professional expertise with personal experience as a mother navigating a complex healthcare journey for her son. I am grateful to her for sharing with me the moving story of discovering her son's condition so shortly after his birth. Miriam discusses with me the difficulties that families all too often encounter when seeking highly specialised healthcare interventions for rare and complex conditions, which can result from a combination of limited expertise and less centralised decision-making at the national level. She explains to me what changes she believes are needed to ensure better outcomes for rare disease patients and their families. Miriam, thank you so much for joining me for this discussion.
Hi, Julian. Good morning.
Before I jump into a discussion with you about your expertise in healthcare for people with anorectal malformations, I would first like to learn a bit more of your personal family's story, which you've kindly agreed to share with us. I understand that your son has an anorectal malformation. How soon after his birth did you learn about his condition, and what exactly is the condition that he was born with?
So anorectal malformation is a condition that is nearly never diagnosed before birth on ultrasound. Families learn about it usually right after birth. When my son was born, I already knew that he had Down syndrome, so I kind of was prepared that things wouldn't be as smooth as with my first son. But from all prenatal testing we did, we still expected a child with no congenital malformations at that time, though we were prepared that anything could show later. When he was born, I first got him back from the first exam and I was told everything is fine. His heart was fine. Everything was fine. But in that moment, even though we experienced immense joy, I already kind of had a feeling that just something didn't feel right. But it took a couple of hours. I think it must have been half a day or so until he was diagnosed with an anorectal malformation. Anorectal malformation is a condition where children are born without a normal anal opening. Some children do not have an anal opening at all, or some have the anal opening mislocated into the bladder, into the urethra, or at the perineum. It should usually show on the first exam. You can just see it. It just doesn't look normal. But I guess in our case, it wasn't checked exactly, so we only found out a couple of hours later.
I imagine that must be a very difficult thing to discover so soon after having given birth. When you learnt about his condition, I'm curious, did your medical background as a surgeon shape your response to his diagnosis? Did it offer comfort, or did it perhaps add complexity to your experience?
I think both happened. In a way, obviously, I could understand maybe quicker than somebody who's not from a medical background what that might mean. And I could, in my head, take first decisions of how I would want things to happen. I could structure myself and make a plan because I kind of understood what road is lying ahead of us. On the other hand, it didn't comfort me at all because I knew this was going to be serious. In addition, even though I am a visceral surgeon with a focus on coloproctology, I didn't have a lot of knowledge about anorectal malformation myself. I had never encountered an adult with that condition before, though it would fall under my subspecialty. But since it is a rare condition and since adults also tend to not seek healthcare as much as they might need it, I had never encountered a patient before. So in a way, yeah, it did comfort me, but it also added complexity to my emotional state at that time.
Because I imagine if you are a surgeon embedded in the health service as well, you might be even more familiar with the health service's weak spots or where there is actually not tremendous amounts of expertise.
I think all of the families at Zoma go through this. We all want to trust the medical system and we all want to trust those doctors treating our children. I had the same thing. As a patient or the mother of a patient, you really just want to trust because you have to. Whether you're a doctor or a lawyer or whatever, in that moment, you are not the doctor treating that child. So you have to trust that person. But for me, obviously, from the beginning, I knew I am going to watch very carefully what is happening and I'm going to participate in decisions and I will take responsibility for my child beyond just being a mother, but also questioning medical decisions.
I see. Do you think that if you had not been a surgeon, his healthcare may have been different upon being born and over the years since his birth?
These children are usually born into families where neither mother or father are a surgeon. A lot of us at Zoma have some sort of medical background, but I think the profession of the parents doesn't really matter. All parents become expert over time. I've had conversations with parents of children with anorectal malformation who are not from a medical background at all. And you would think they are medical experts because they became experts. It's just a matter of how quick you become an expert, how quick you can understand the decisions that are being made, or how quickly you can also start getting involved in decision making. And I guess for me, I could start quicker to say this might not be the correct way. We might have to go another way. But all families will get a good knowledge of the condition at some point because they just have to.
I think that's an experience that resonates with people right across the rare disease community. Patients kind of have to become medical experts in their area because doing the necessary research around one's own condition or the condition of the family member plays such an important part in obtaining what is needed in terms of healthcare. I haven't asked actually, how old is your son today?
He's 4.5 years old now.
How is he doing? And what has been his healthcare journey like up to now?
I think he's doing very well now. The journey he went was really tough at the beginning, but he could develop really well once the operations and all the medical issues were overcome. So with an anorectal malformation, the problem is that the normal intestinal passage is not there. Most of the children, about 2/3, need an operation very early after birth. And that operation is usually the placement of a colostomy. Through that, the emergency situation is dissolved. There is no time pressure anymore. The baby has time to grow. The parents have time to gather information, orient themselves, take their child home, grow as a family. And then at a later point in time, usually with 8 to 12 weeks of age, the corrective surgery for the anorectal malformation can be performed. It's a very complex surgery. It has to be performed by somebody who has very good knowledge and experience of that condition. And that is why it is important to give families this time of planning and growing and being part of the decision making. And then once the corrective surgery is performed, at a later stage, the closure of the colostomy in a third operation is performed, and then the surgical part of that condition is over. And then the next part starts that is, I think, equally important, and that is really the aftercare, bowel management. The children do need support for the rest of their life. Some children have also urogenital problems with the bladder and they need urological support. So that is roughly what the patient journey looks like. For us, it looked a little bit different because my son was unfortunate in the way that the first operation didn't go as it was planned to go. And 5 days after the placement of the colostomy, his colon burst and he went into septic shock and coma. But he came out of it, and after the corrective surgery and another 6 months, he could get his colostomy closed. And that's when we really celebrated the first set of operations being over.
Well, I'm glad that during the journey there was a successful ending. I imagine that would have been traumatic. Do you know if that's like a common occurrence in the healthcare journey of people who are born with this condition?
No, it's not a common occurrence. I think trauma really comes from, without me being a psychologist, from not being in control of a situation, right? If you have to give your child away to a surgeon, then you realize, okay, you're not in control. Somehow those people treating the patient are also not so much in control of what is happening. I think that's what causes trauma. I think it's not the severity of the disease or the severity of the malformation. It's really just how it is handled. And if healthcare workers involve parents or patients in that process, the trauma can be much less. I would urge my colleagues to really pay attention of not excluding parents from the treatment of their child, but really involving them and taking them through that journey.
That's an interesting perspective. So what motivated you to get involved with Zoma, the German organization advocating for and supporting people who live with anorectal malformations? Could you share more about Zoma's mission and how it supports families like your own affected by ARM and similar conditions?
Yeah, so I think I'm a typical Zoma family in the way that I only really contacted Zoma after all the operations were done. I don't know why I didn't contact Zoma earlier, but somehow there's a barrier for everyone, I think, to seek help with a self-help group. It's not a club I ever wanted to join. It's not like I ever saw myself in a self-help group for a congenital malformation. But once you reach Zoma, it's a very good place to be. So I contacted Zoma when all the operations were done, and I somehow felt like in the aftercare of the operations, we didn't find help with any doctors. The pediatric surgeons told us everything is fine, but we experienced problems at home. The normal passage of stool was difficult, eating was difficult, caring was difficult, and we didn't find anybody helping us. And that's when I contacted Zoma, and really Zoma was of immense help with all these problems.
Interesting. From Germany, what do you believe are the most critical changes that are needed to improve healthcare for people living with anorectal malformations?
I think the root to most of our problems with finding specialized care is really the problem of a decentralized care for people with anorectal malformation.
Right.
I didn't know that at the time when my son was born, but I only slowly realized later and through the work with Zoma that is not something unique to us, but really a systematical problem. And it is mainly caused by the fact that anorectal malformation is a rare condition. It's not ultra rare. It's about 1 in 3,000 newborns that have that condition. So that's 300 cases in Germany per year. But then these cases are treated in roughly 120 pediatric surgical units. So pretty much anywhere these children are born or transferred to directly after birth, this condition will be treated. No pediatric surgical unit transfers children because they say we have very little experience or we haven't performed this yet. I think if you don't perform corrective surgery very often, you won't have enough experience also to provide proper aftercare or even transition of care into adulthood. I think a main problem is that anorectal malformation, same as Hirschsprung disease or esophageal atresia, is considered the center of pediatric surgery. Pediatric surgery is a specialty that is young. It only developed in Germany in the 1960s before pediatric conditions were treated just by general surgeons. So creating that subspecialty or that specialty is really an achievement for children's rights. Just that since that development, not much has developed in this specialty. While adult surgery started to subspecialize. Nowadays, you have adult surgeons focusing on upper gastrointestinal surgery or coloproctologists or urologists. The pediatric surgeons is really everything. He or she treats every organ as long as it's in a human below 18 years old. So there has not been any subspecialization, and that's why rare conditions like anorectal malformation and Hirschsprung disease are really in the center for every pediatric surgeon. So if you are a pediatric surgeon and you say, I don't treat anorectal malformation in this hospital because I don't do it here very often, you will probably be questioned if you are in the right position. And
Right.
that leads to every pediatric surgeon continuing to treat that condition.
I see, I see. So do you feel like that is what's responsible for more places than should be the case, delivering these specialized surgeries for those with anorectal malformation? Do you feel the healthcare systems compel pediatric surgeons to offer the surgery, even if in an ideal world they maybe would not?
Completely. With this system, with pediatric surgery as a specialty continuing to treat every case, regardless whether it's a complex case or whether it's just a small hernia, this is really damaging to everyone. It's not just damaging to the patient, it is also damaging to the specialty of pediatric surgery itself, because it's holding it back. You don't need 120 hospitals treating 300 cases. And we know that it can be organized in a different way because congenital heart defects are organized in a different way. There are 3,000 congenital heart defects in Germany per year, and they are treated in roughly 20 hospitals. And that is really a centralization that is the basis for any improvement.
You know, it's really interesting that you point out that on the one case, anorectal malformations don't have these centers of expertise, but this other condition does. Are you aware of there being perhaps more unsuccessful outcomes in complex surgeries for anorectal malformation than you believe there should be due to this lack of centralization? And what do you think is the root cause of decentralization in Germany of these surgeries?
Two very big questions that have been the center of my work at Zoma for the last 3 years, I think. The first question you're asking is basically whether there is a volume-outcome relation. This is a term set in public health research. For everyone who's not into research, it would be common sense. If you do something more often, you do it better. A lot of people outside this community that I explain my work at Zoma or even my research work to, they think like, yeah, but why do you need to research this? I could have told you this before. If you do something and you only do it once a year, it will probably not turn out that well. Unfortunately, policy making needs research, and that's why we do need to research the volume-outcome relation. Volume-outcome relation has been researched for pretty much every complex surgical procedure in adult surgery, and for nearly everyone it has been proven. In pediatric surgery, I've started with a group of researchers to research volume-outcome relation in Germany, and in our research about anorectal malformation, also Hirschsprung disease, we were not able to show a volume-outcome relation. But we kind of knew this when we started. We still did the research because we wanted to collect the numbers to see caseloads per hospital. The problem with showing the volume-outcome relation in pediatric surgery is there are 4 reasons. Firstly, the conditions are rare. I mean, 300 cases is not a lot. Then they are decentralized and distributed. So we don't really have hospitals with high caseload that we could compare with. If you want to show a volume outcome relation, you would want to compare hospitals that have less than 5 cases to hospitals that have more than 20 cases. But we don't have that in Germany. The median caseload in the higher tercile of hospitals for anorectal malformation was 10, and for Hirschsprung disease it was 7. So you can't really show a difference in outcome if you're comparing hospitals that do something 3 times to hospitals that do something 7 times. They are probably all not doing this surgery as often as you would have to. And then the third problem is that especially children with anorectal malformation are complex. There are different forms of anorectal malformation. So you have very few cases in total. In addition to that, these cases differ completely. The fourth problem is outcome in pediatric surgery is usually not death. If something goes wrong in an operation, the child will very likely survive, but the outcome might be a long-term outcome like incontinence or infertility or urinary incontinence. And these outcomes are much harder to measure. So these are basically the reasons why it's very hard to show a volume outcome relation. For Germany, we weren't able to show it. still we were able to show that there is a methodological reason that we cannot show a volume outcome relation. So we have to acknowledge it cannot be shown that there is a volume outcome relation, but it can also not be shown that there is no volume outcome relation. So we have to now start looking for indirect evidence. And indirect evidence for this volume outcome relation is basically that for the common colorectal surgery of adults, there is a clear volume outcome relation. How can there not be a volume outcome relation for the exact same procedure in the pediatric population?
It sounds like a very, very frustrating problem because, of course, it makes total sense what you say about how if the data is there for adult surgeries, the idea that you can't draw the right conclusions for pediatric surgeries, it's kind of absurd. But of course, like you say, you can't prove that this very logical conclusion or reality isn't the case for pediatric surgeries. What do you think is preventing the German health system from centralizing specialized surgeries for children with anorectal malformations? Do you believe that the problem stems from difficulty in the research, or do you think the causes are something broader? Do you think the causes are something cultural in the medical system, or do you think it's something to do with legislation or economics?
I think in Germany, a lot of the responsibility about who provides what kind of care was given to the hospitals or the doctors. It is really just up to pediatric surgeons to decide what kind of procedure they can or cannot perform in these hospitals. And then incentives are high. You want to be a specialist. You want to be the one helping these children and developing new techniques in pediatric surgery. I think Zoma has been advocating for centralization of care for anorectal malformation and Hirschsprung disease for the last 35 years, basically since its existence. It has been always a central question. Where should we go with our children to get the best kind of care? And this problem remains unsolved. And in Germany, there's a change happening now, but this change is firstly for the more common diseases. So I guess the advocacy for people with anorectal malformation, Hirschsprung disease, or other congenital anomalies is really needed right now. Even though we have children with a rare disease, the impact on the health system is a big one because our children usually survive and live with this condition their whole life. And the way they can work and participate in society, or how much health care they need, or how much further operations they need, is really decided by the quality of this very first corrective surgery. This is a crucial point, having such a big impact on society and on the healthcare system, and also producing costs. This needs to be regulated, and we need to put measures into place to ensure more quality than there is. So to my understanding, really the best quality measure to start with is to put a mandatory minimal caseload. Any hospital that performs less than 5 cases, to my understanding, is unacceptable because these places cannot gain enough experience to perform safe surgery. Families might be lucky, surgeons might be lucky, but we need a good quality control for each and every case.
That's a really important point. And it's interesting, of course, that lots of these decisions about the delivery of a surgery fall to individual pediatric surgeons. Is that correct? Whose incentives are kind of perverse, essentially. They probably understandably want to gain experience in a new surgical area, but they may not think they would be making a decision that is not in the interest of the patient. But also they are biased, do you think, by the incentives they have to, perhaps with good intentions, expand their portfolio?
Yeah, I think that's some of the dynamic at play. And being a surgeon myself, I really don't see that they have bad will. I just think it's the way the system is wrong. We have seen no trend for centralization in Germany since the year 2017, in which first the ENICA certification and the EURORDIS certification was given to hospitals in Germany. So I think it's really an effort that has to be made on a public health level and a policy level. And I don't think the clinicians or the pediatric surgeons are the right people to steer that process, because there are so many competing interests in that. I think we as a patient organization can advocate for it. We can continue to have a good relation to the clinicians and the pediatric surgeons for most of our activities. And we can seek them as expert help for the process of centralization, but the process will not be steered by pediatric surgeons. We really need the policymakers to help us here.
So based on the advocacy that's been done by Zoma, do you feel like policymakers have been receptive and understanding of what Zoma has been advocating for with regard to making sure that there is more centralization of these surgeries?
Over the recent years, policymakers have been receptive to our advocacy. There is a huge advantage that we have when it comes to centralization of care. And it is really that we truly believe centralization of care improves quality of care. And improved quality of care will reduce costs in the healthcare system. So we need to, as patient organizations, look less to the clinicians for help when it comes to policy making, but really to those who will pay for these services. Because when it comes to money, things can change very quickly.
Well, that's a really, really important point about targeting policymakers for change like this. If I were to ask you, as a surgeon yourself, as well as the mother of someone with an anorectal malformation, what would be your advice to other surgeons and healthcare professionals who deal with families impacted by not just anorectal malformations, but rare diseases in general that may require specialized surgeries? Would you have any advice for them?
Yeah, in a way, the question you're asking is my own mental journey after I had my second son. I questioned myself many times if I would ever want to work in surgery again, because the way I experienced the patient journey with him was that there were sides. There was the doctors on the other side and us on this side. And I really think this doesn't have to be, this shouldn't be. We have children as a society and we need to care for them. And some people in this society become teachers and some become surgeons, and they happen to be the ones caring for children affected by malformations. So my advice for my colleagues is really just don't stop looking at other humans as fellow humans. You are here on the same side. There should not be a wall between doctors and patients. Sometimes I'm on the patient's side, sometimes I'm on the doctor's side. In the end, it's all the same.
No, that's a really important point. Do you feel optimistic about the continuing healthcare that your son will receive in future? And for families who in future may have a child born with an anorectal malformation, or in fact any other rare disease, do you feel optimistic about the healthcare that they will receive?
Yeah, I feel very optimistic about the changes that are trying to be made. I think the process of centralizing highly specialized surgical care in Germany has started. But right now, for children being born today, nothing has changed. But research is going towards volume outcome relation. Health policy making is focusing a lot on volume outcome relation. So I think we have a chance to change things in the future. And I hope that patient organizations will be actively involved in that. This is the most motivating thing about the work with Zoma, that we do feel we can participate in change. But have we made any progress yet? For those people being born today, no.
It's really brilliant that you are motivated to affect change in this area, as well as optimistic about the prospect of change. Hopefully the changes that need to be seen are made, because, of course, it's important that every child and anyone with any rare disease receives the best possible care, especially when it's a specialized surgery. So, Miriam, thank you so much for joining me for this discussion today. It's been really lovely talking with you. Thank you.
Thank you very much.